Welcome everybody to the Global Frailty Network Frailty Seminar Series. My name is Dr. Carmen Castillo Gallego. I'm a geriatrician in Spain. And our speaker for today is Dr. Giuseppe Bellelli. But before introducing him, I'm going to remind you that if you have any question at the end of the talk, you should use the chat, which is in the bottom right of your screen. Dr. Giuseppe Bellelli is a full professor of geriatrics and internal medicine and the director of the School of Specialization in Geriatrics at the University of Milano-Bicocca. He's also the director of the Acute Geriatrics Unit Fondazione IRCCS Ospedale San Gerardo Fonza, Italy. He is also a member and lecturer of the Public Health Epidemiology, Statistics, and Economics program of the University of Milano-Bicocca. Professor Bellelli is the president of the regional section of the Italian Society of Gerontology and Geriatrics and served as a national board member of the same society from 2014 to 2022. From 2020 to 22, he was the national vice president of the Italian Association of Psychogeriatrics. From 2018 to September 2023, he was the coordinator of the Delirium Special Interest Group of the European Geriatric Medicine Society. Finally, Professor Bellelli is a member of the board of directors of the Ravasi Galzanti Onlus Foundation. Professor Bellelli is the author or co-author of over 300 scientific publications in international journals. He's also the author of 3 books and several chapters in Italian and English. He has served as associate editor for BMC Geriatrics, Frontiers in Medicine, Geriatrics Medicine, and he is current associate editor of journal Frailty and Aging, and Minerva Medica. He is also the recipient of various competitively funded projects and is the WP leader of Spoke Partnership 8, PNRR-HE, a novel public-private alliance to generate socioeconomical, biomedical, and technological solutions for an inclusive Italian aging society. Today he's going to talk about delirium and frailty in older adults.
Thank you for this presentation, which exponentially increases the expectation of the audience. This may be a problem, but anyway, thank you. Really, thank you. This is the title of my presentation. When Professor Ruiz, first of all, I would like to thank Professor Ruiz for giving me the opportunity and the honor to officially open the frailty seminars of the UGMS with this presentation. Second, I would like to explain why, how I have prepared my speech today. When he entrusted me with the topic of today's speech, I asked myself, well, what could I say that be innovative to an audience of geriatricians with, for sure, expertise in delirium and frailty? So I tried to imagine offering you a fresh perspective of the two conditions for interpreting these two conditions, possibly presenting delirium and frailty not as separate entities, but in a joined condition as potential interconnected entities. The question you can see here is not a trivial question. Delirium, for many years and probably still now, has been considered as a brain-related dysfunction or a mere behavioral problem without impact on body and bodily function. While frailty has been considered as a locomotor dysfunction or a non-specific measure of accelerated aging. And the role of cognition in capturing frailty is poorly understood. However, if we look at the two conditions, we can try to find many commonalities. Take a look at the definition. Delirium is an age-related syndrome with acute change in cognition, mainly attention and awareness, and fluctuation of the symptoms. It has a wide range of potential causes, often is multiple causes, and it has several psychomotor subtypes. Frailty is an age-related, clinical identifiable state of diminished physiological reserve and biological homeostasis, with increased vulnerability to a broad range of adverse outcomes. It is multifactorial and complex. Even we consider it either a syndrome or a state. In this definition, we can find at least three commonalities. Both conditions are strictly related to the older age. Both are multifactorial, and both are complex. But you know, the commonalities do not end here. Delirium is very prevalent among, especially among hospitalized older patients, 1 in 5 or 1 in 4 according to the different studies. And frailty too is very prevalent in community dwelling older people, with a prevalence of about 12-13% among community dwelling older adults, reaching 25% among people aged 85 years and older. In addition, both conditions have several outcomes in common, including risk of hospitalization, risk of institutionalization, risk of mortality, new onset disability, falls, both increase healthcare expenditure, and both increase social value. So looking at this characteristic, it is not an easy that you can find delirium and frailty coexisting. But importantly, this condition has also risk factor in common. This is one of the very numerous paper, a lot of paper talking about the risk factor for delirium. This is a figure from the excellent review by Joe Wilson on Nature. You can see here the premorbid risk factor. There is a list of 12 risk factors. This is a study showing the risk factor for onset or progression of frailty. There are a myriad of risk factors, but both for delirium and frailty, but many of these risk factors are in common. Older age, low education, loneliness and isolation, depression are predisposing factors for both delirium and frailty. Chronic pain has been shown to nearly double the risk of developing frailty, and a recent systematic review and meta-analysis has shown that both pain at rest and pain with movement increase delirium risk in older patients by over twofold and by 1/3 respectively. Insomnia and sleep disorders can also influence frailty occurrence and can predispose individuals to postoperative delirium as well. Undernutrition is known to triple the odds of frailty and quadruple frailty risk in the long term, and it's also risk factor for postoperative delirium and multimorbidity, which is twice as common in frailty individuals, predisposed to both frailty and delirium, with a threefold increased delirium risk associated with higher multimorbidity burden. Importantly, frailty and delirium share also many clinical features. In this slide and in the following two slides, The shared sign and symptoms of delirium and frailty are presented, categorized into motor, cognitive, and affective domains. The signs and symptoms of delirium were derived from the diagnostic criteria of DSM-5, ICD-10, and ICD-11, while those of frailty were drawn from the items included in the most used frailty assessment tools, of course, excluding the frailty index, as is may include the cognition in the final calculation of the value. Here you can see that, for example, regarding the motor domain, delirium, as you know, may present with as hypoactive or as hyperactive, or also are the mixed delirium with different motoric activity level. It can also involve the flow of the speech and the reaction time. And of course, motor impairment are typical of frailty people, of frail people. But also we can see here that problems with memory and cognitive impairment and difficulty in coping with problems is reported for people with frailty, as well as, of course, for people with delirium. In addition, some disorder of the affective domain is reported in both the criteria to define delirium and the tool to define frailty. An intriguing question, in my opinion, is if there is a bidirectional relationship between the two conditions. This is particularly important because it is, well accepted that frailty can predispose to delirium. This is a systematic review and meta-analysis of the literature from our group, which we published some years ago, including 20 out of over 1,600 articles. Of the 20 articles, 8 were eligible for meta-analysis. And you can see here, frailty was associated with an increased odds of developing delirium by 2.19. In a subsequent systematic review and meta-analysis, including a larger number of articles and, of course, a larger size of sample, frailty was very prevalent, as you can see, and confers an odd of increased risk of delirium nearly around 3. It is particularly of particular interest that the authors in this meta-analysis assess the different impact in terms of risk of delirium of the different frailty tools, findings that those with greater emphasis on cognition will more likely to demonstrate association between frailty and delirium. A different question is whether delirium may predispose to frailty. And as far as I know, there are no studies which assessed, which try to answer this question, excluding this study, which is a study conducted in patients with cardiovascular disease undergoing cardiac surgery, with a follow-up of nearly 3 years. And as you can see here, people with delirium had an increased risk to develop frailty in the panel B, it is more easy to appreciate that the combination of delirium and frailty increases the risk to develop frailty. This is the only study, as far as I know. Unfortunately, a limitation of the study is that the author did not consider the level of frailty both before and after the surgical procedure, nor they considered the impact of dementia in mediating the association between delirium and frailty. However, this is the first study, and I hope that future study on this topic will be conducted in the next year. Anyway, the notion that delirium and frailty can feed each other in a spiral downward is also supported by several studies, demonstrated that delirium is a risk factor for functional decline in some categories of patients, and also that the functional decline following delirium can lead to dementia if delirium is unresolved. Of course, there are several pathophysiological mechanisms which can be involved in both conditions, and there are studies to support the involvement of the following pathophysiological mechanisms: inflammation, neurodegeneration, cerebral and muscle metabolism, vascular burden, and gut microbiome, both in delirium and frailty. Here you can see summarized the overlapping pathophysiological mechanism in a circular relationship where frailty and delirium separately but also jointly and interconnected can lead to, you can see here, a number of adverse clinical outcomes. So one question that may arise is the following: can we hypothesize a unifying conceptual framework for interpreting the interconnection between frailty and delirium? I think that we can state with a sufficient degree of evidence that frailty predisposed to delirium. It may be that delirium belies an underlying condition of frailty, much like delirium serves as an indicator of the presence of dementia. And according to this perspective, frailty may represent the critical component determining why a person of the same age and with the same disease may develop or may not develop delirium under similar circumstances, like as, for example, when experiencing pneumonia or a fracture. Okay. Of course, higher the damage accumulation, so the degree of frailty, even taking into account the resilience, which may be different from individual to individual, the higher the likelihood, the probability that a person will develop delirium. A different answer is regarding the fact, the idea that delirium can predispose to frailty. This is less explored, as I said, just a few minutes ago, but in my opinion, it is very intriguing as a question. And to try to answer this question, I would like to take first take a step back and try to create a parallelism between delirium and dementia. I mean, how delirium can lead to dementia, and with how delirium can lead to frailty. These are data from a seminal paper by Daniel Davis and his colleagues published many years ago in JAMA Psychiatry, with, as you know, nearly 1,000 of individuals who underwent autopsy after death. Data were obtained from 3 observational cohort study with population-based sampling, the Vanta 85 plus study, the Cambridge City over 75 cohort, and the cognitive function and age study. People were followed for a median of 5 years until death. And what Daniel Davis demonstrated in this paper is that delirium accelerated the trajectory, the trajectory that lead to cognitive decline and dementia, accelerated the process of dementia, but that the pathophysiological mechanisms which are known to be involved in dementia, especially Alzheimer's disease, as you can see, amyloid, infarcts, loss of neurons, alpha synucleopathies, and APOE were not involved in patients, were not overrepresented in patients who develop delirium. As to say that delirium can lead to dementia through different mechanisms that normally are involved in the pathophysiology of Alzheimer's disease. And this study was also confirmed by another study conducted by us in collaboration with Dr. Frisoni from Geneva, in which, if I remember well, 20 patients, nearly 20 patients, underwent amyloid PET scans with flutamidazole prior to surgery. And as you can see here, there was no difference in terms of amyloid burden in those who developed delirium from those in comparison to those who didn't develop delirium. And this is particularly important for the understanding the next slide. More recently, Maria Croxett and the group of Daniel Davis conducted a prospective study with a 2-year follow-up of older individuals receiving home care in Norway. About 2/3 of them had moderate to severe frailty at baseline. And this is the flow diagram of the study. And, you know, as I have already said, nearly 2/3 of individuals had some degree of frailty, ranging from mild to moderate to severe frailty. And particularly importance, nearly half of the population have already pre-existing dementia before developing delirium. What did the author find in this paper? The author find, in my opinion, very important results. The first is that people who develop delirium has an increased risk to have neurofilament light. As you know, neurofilament light is a marker of neurodegeneration and inflammation. So people with delirium and increased concentration in the blood on neurofilament light on admission, and importantly also at the end of the follow-up. And the other important finding is that delirium, in addition to neurofilament light, elevated concentration of the blood, were important mediators in the development of cognitive impairment, in the worsening of MoCA score at the end of the follow-up. So it might seem that delirium, probably through mechanism of inflammation and neurodegeneration and other pathophysiological mechanisms that are not the same of those implicated in dementia, may lead to cognitive deterioration. And this is of particular importance because neurofilament light chain is also increased in patients with severe sarcopenia. These are the results of a sarcophage study, which is a study on community dwelling older adults, 500 community, more than 500 community dwelling older adults with an ongoing 10 years follow-up. And sarcopenia diagnosis, sarcopenia was diagnosed according to the European Working Group on sarcopenia criteria, and neurofilament light was measured on all available sera collected at the time of the inclusion using Simoa technology. As you can see here, sarcopenia, NFL light concentration were elevated in people with sarcopenia. And this is of particular importance because sarcopenia, as you know, is one of the key elements characterizing frailty. And so it may be that there is a parallelism between neurofilament light, delirium, sarcopenia, and therefore frailty. The data that link sarcopenia with the brain and cognitive performances are growing. This is a very important study published on brain communication at the end of last year, where more than 33,000 participants, UK biobanks, underwent structural and diffusion magnetic MRI of the brain, underwent an assessment on the muscle fat infiltration and sarcopenia, and an assessment and evaluation of the general cognitive performances. And what the author found was that there was a direct effect of the muscle on the brain and also on the cognitive performance, with an indirect effect via mediator of the brain condition. You can see here that people with tricortical thickness has lower cognitive performance, and similarly, individuals with reduced brain volumes had lower it increases sarcopenia risk in this study. So it might seem, it looks like that the axis that relate muscle, brain, and body should be explored with future research. In the last 5 minutes of my presentation, I will talk about the implication for clinicians and researchers from this study, from this presentation. An important implication, in my opinion, is that frailty and delirium should not be regarded as separate entities, but as interconnected conditions, with each having the potential to trigger the onset of the other. I think we had sufficient evidence that frailty can predispose to delirium, not so much that demonstrate that delirium can predispose to frailty, but we have the rationale to conduct or to try to conduct this kind of research. And in my opinion, it is likely that in future this idea will be supported by several studies. An implication for clinicians is that frailty, early identification of frailty may help reducing the incidence of delirium. I don't know whether in all geriatric wards it is common or it is routine to assess frailty, but I guess not always this is actually done. But for sure, frailty may give us some information about the potential of individual, the vulnerability of individual to develop delirium, and probably prevention should be focusing especially on the frail patient. Furthermore, intervention to mitigate the impact of delirium and thus of worsening frailty should be fostered. What does this mean? This means that probably all patients with delirium should be assessed in the short, medium term, not only for the development of dementia, but also for the probability, for the possibility to develop frailty. And we need study to assess both frailty and dementia as potential outcome for them. Another implication, in my opinion, is that one overarching hypothesis is that frailty and delirium can be alternative and sometimes co-occurring manifestation of an underlying accelerated aging process. Frailty is sure to represent a proxy of accelerated aging, but if we think of delirium as the potential, as a marker of frailty, as the more clear evidence that the individual is frail, we can think of delirium as in the same way as an underlying as a marker of underlying accelerated aging process. And therefore, from a research perspective, it might be useful to explore common molecular, cellular, and physiological pathways that underpin both conditions. I presented some data regarding the neurofilament light change biomarker, but I am quite sure that other biomarkers, such as, for example, the GFAP or some interleukin, may be increased in the blood of patients with both delirium and frailty, and probably studies in a combined manner, they can be more informative that studied alone or in isolation. So before concluding, I would acknowledge many of the people who helped me to try to share ideas to try to study this topic and to explore this topic. This on the left side of the slide are my collaborators every day, and would like to thank all of you sincerely. And these guys are researchers that collaborated with me in the publication of the recent article on Journal Internal Medicine, which include most of the ideas I have talking this evening. Thank you very much for your attention.
Thank
And
you so much, Dr. Bellelli. We have some questions. Sorry, Sammy. You were going to say something?
Sorry?
Were you going to say something?
No. Thank you.
Okay.
I would like to thank you for for your attention and to thank all of the participants for the same.
All right. Thank you so much. We have two questions from William Davila. How can current assessment tools be redefined to simultaneously evaluate the risk of or presence of both frailty and delirium in older adults?
Sorry, can you repeat?
Yes.
A problem?
Yes. How can current assessment tools be refined to simultaneously evaluate the risk of, or presence of both frailty and delirium in older adults?
This is a really nice and important question. Unfortunately, in my opinion, there are no tools currently that can allow us to assess simultaneously these two conditions. One of the problems of both delirium and frailty is that the definition of these two conditions is mainly based on clinical criteria, which is a problem, or they can be diagnosed only by using tools, but clinical tools that again are based on clinical criteria. Probably we need some biomarkers, okay, and I hope that blood biomarkers, for example, like we are seeing that, of course, for Alzheimer's disease, okay, you know that many biomarkers of Alzheimer's disease, for example, p-tau 217, probably will become available in the future months, and these biomarkers can help physicians to identify individuals who are very likely to develop Alzheimer's disease. I think that we need to work on delirium and frailty and try to develop studies that try to identify simple and simple to obtain, of course, probably blood-based biomarkers are the ideal, that can help us in identify at least individual at risk. But the clinical tool, in my opinion, today cannot help us in this task. Anyway, we need to assess frailty using frailty tools and assess delirium in all patients, especially in the hospital, because the risk that these two conditions overlap that present simultaneously in the same individual is very relevant.
Another question from William Davila. How do social determinants of health, such as socioeconomic status, education, and social support, influence the relationship between frailty and delirium?
Yes, this is another good question. To be honest, I don't know, but frailty is more likely in individual with economic economic disadvantage, with social with lack of social support, and probably frailty may represent a kind of a kind of silos where also a lack of social support, economical disadvantage, and other deficit converge. So it is very likely that this kind of individuals will be more at risk to develop delirium. But again, as far as I know, we have no study that demonstrated that single component of frailty, because lack of social support is a component of the whole concept of frailty, can predispose to develop delirium with a different impact with respect to other components.
It may have something to do with cognitive stimulation, the lack of cognitive stimulation, with the lack of social support or interaction, maybe depression too.
Yeah. As you in one of my first slides, I reported the common risk factor for both delirium and frailty. And as you know, in the first, in the upper side of the slide, were reported, in addition to age, were also reported loneliness, isolation, depression, and lack of education. Of course, these are predisposing factors as much as they are predisposing factors, for example, for dementia. At the end of the day, delirium is a sign of cognitive impairment, similar to dementia. The difference is that delirium is an acute cognitive impairment, while dementia is a chronic cognitive impairment. But they are, of course, within the same domain, so it is obvious and it can be expected that the risk factor for dementia may be the same for delirium.
Okay. We have another question from Asia. Would the relationship between delirium and frailty be better understood if we measured physical frailty versus cognitive frailty as two separate outcomes factors?
Yeah, this is another very good question. When I talk with my friend Matteo Cesari, that probably most of you well know as one of the main experts of frailty, he always said to me that when you are talking about frailty, you cannot separate the components of frailty, because the concept of frailty is a unitary concept where several components determine frailty. So it is difficult to separate physical frailty from cognitive frailty. Said that, in my opinion, delirium should represent an indicator of cognitive frailty if we think of frailty as a condition that increase the vulnerability towards adverse effect. Delirium, may predispose to dementia and also to frailty. So it is obvious, it is natural to consider delirium as a indicator of vulnerability. And probably it is an indicator of cognitive vulnerability. And, you know, it may be, it may have, I hope that in the future, some studies could try to develop, to delve deeper into this concept, because it may be useful for both clinician and researcher to explore more in depth the relationship between the two conditions.
Thank you. Another question from Tanya. How do specific comorbid conditions such as cardiovascular diseases or diabetes affect the interplay between frailty and delirium?
Okay, this is another very relevant question. However, to be honest, when I talk about frailty, I think as a condition which include chronic disease in the definition. As you know, frailty, if you think at the frailty index is composed by several signs and symptoms, comorbidity, functional decline, other conditions. Okay, so frailty, as I have already said, is a unitary concept, and in my opinion, it is not correct to separate frailty from multimorbidity. However, it may be that some chronic disease, even in addition with other, so this is to understand, the important is to understand the relationship between multimorbidity and frailty. It is, however, it may be that some chronic disease may be more informative in terms of the relationship between frailty and delirium than others. And probably cardiovascular diseases and diabetes are among these. So we need some study.
I have another question for you. How does the severity of and duration of delirium episodes influence the acceleration of frailty in older adults?
Sorry, can you repeat again?
Yes. How does the severity and duration of delirium episodes influence the acceleration of frailty in older adults?
Okay, this is a very, very important question. All questions are really nice. Thank you very much for your questions. To answer this question, or I'm not sure, but probably the guy who asked me this to talk about this point has in mind the paper, a recent paper by the group of Daniel Davis. Mm-hmm. Again, I'm not sure the Cascade study or another study, but anyway, they explored whether the severity of dementia and the severity of delirium affected the acceleration of cognitive decline, and they appreciated a U-shaped relationship between. The more severe is delirium, the higher the likelihood to develop to accelerate cognitive decline. Mm-hmm. And I think, in my opinion, that also duration of delirium can affect the acceleration of cognitive decline. I remember some study from the group of Vanderbilt University in ICU patient, where duration of delirium increased the risk of cognitive decline at 1 year follow-up in patient in the intensive care unit. And I think there is no reason to doubt that this is not the case in individual from geriatric wards.
Another question, and this will be the last one. What are the most effective interventions to prevent the transition from frailty to delirium and from delirium to frailty?
How many hours have I to answer it? But
not
how
many.
much
We
time?
have 10 minutes.
A few minutes. Well,
it's a difficult question.
yeah, the prevention of delirium, you know, you need to follow the suggestion of the main guidelines on delirium. For example, the Scottish, the NICE, and other. But I think there is no reason to follow different suggestions because the patient is already frail. So prevention of delirium today can be done using the well-known, targeting the well-known risk factor for delirium. However, quite different is how can I prevent frailty from delirium? This is another question because today we have not studies, and also we need some study in this field to understand whether the using, for example, cognitive enhancers or drugs like such as acetylcholinesterase inhibitors and others like that can prevent dementia after an episode of delirium, and then as a consequence can prevent frailty. Another target of intervention may be, for example, to focus on the muscle of the individual, and probably offering some proteins in the diet or supplements may be useful, but we have not studied to clearly say to us what to do. We need to study, and I hope that many of the participants today can be inspired to conduct such kind of studies.
But maybe individuals with delirium at hospital, when they are discharged, should be the subject of intense treatment to prevent frailty because they are at higher risk, I guess.
Yes, yes, yes.
Exactly. So nutrition, physical exercise, and all the things that we know so far. So thank you so much, Dr. Bellelli. I would like to remind our audience that our next seminar will be on February 12th. It's called Expanding Frailty Assessment and Management in Clinical Practice by Dr. Megan Huizing-Sheets from the University of Chicago. Thank you so much, everybody, and see you in 1 month.